All right, now we're going to move into heat exposure. Again, the normal body temperature is 98.6 or 37 C. And the body is really pretty adept at performing thermolysis, which is ridding itself of excess temperature. And this is done by a couple of mechanisms. One of those is dilation of the peripheral blood vessels, so we'll kind of radiate heat out through the blood supply and the capillary beds all throughout the skin. And then sweating. And sweating, again, is the evaporation of liquid off the surface of the skin. And this primarily works best when we have lower levels of ambient humidity. Hyperthermia is defined as a core temperature of 101 Fahrenheit or 38.3 C. Now, some of the contributing factors to heat illness is going to be high air temperature. It's a hot desert-like situation. There's high humidity, which does not allow us to actually sweat and radiate heat off. And then when we're performing vigorous exercise, and so that's creating a tremendous amount of heat as a byproduct of metabolism, and when we've increased metabolism, we increase body heat. The signs of severe heat illness are no different than any other illness, and that it generally shows up with the altered mentation or the differing levels of consciousness. Almost all of them are going to have some kind of sign of dehydration. The people at greatest risk for heat illness are going to be children and elderly patients, and this again is because they're unable to actually compensate for the environmental conditions. And then people with heart disease, COPD, diabetes, and chronic dehydration or obesity. These patients are all with some form of cardiovascular problems or the inability to actually kind of perfuse in a really good way. And then patients with limited mobility are the patients who are unable to evacuate themselves from the condition that's causing the heat injury. Obviously, the other contributing factors are going to be the length and intensity of the exposure and what the environment is actually like. You're much less likely to get a heat injury in 85-degree weather than, say, 117-degree weather with almost 100% humidity. So some of the preventative measures to protect yourself from a heat emergency is obviously adequate fluid intake. If you're sweating, you need to replace that fluid. And unfortunately, the body has to acclimatize to the environment. And so this generally is one of those things where in the initial stages of late spring, early summer, we tend to profusely sweat because we're acclimating to the new temperature outside. And then as it gets a little bit deeper into summer, as we acclimatize to the environment, we will actually start to sweat a little bit less. And we're obviously trying to limit our exposure to those extreme conditions. Drink water continually, which is maintaining your adequate fluid intake, but not just water all by itself. Sometimes you're going to have to add electrolytes back to that because as we initially start to sweat very early in the summer, there's going to be an excess amount of electrolytes that are coming out with the sweat until the body kind of learns how to conserve what it wants to conserve. So if you're going to spend time outside in the summer, you should be doing it in the early morning or the late afternoon because we really don't want to be in the crux of the heat of a hot summer day where the sun is at its highest point and we're actually in our higher temperatures. So we're going to go down the two kind of different pathophysiologies of heat exposure, and this is heat cramps, and then we'll ultimately get into heat stroke. Heat cramps are painful muscle spasms that occur after vigorous exercise. They don't only occur when it's hot outside, but really we're not too sure what the mechanism is. And so again, that sweat changing the body's balance of electrolytes generally kind of happens early in the season as we're kind of acclimatizing to the conditions. And the muscles that are affected are usually the legs or the abdominal muscles. Now we're going to move a little bit deeper, and this is heat exhaustion or heat prostration, heat collapse. This is the most common illness caused by heat. And this is a result of losing so much water and electrolytes through heavy sweating that hypovolemia occurs. And these patients are still very much conscious, but when you take their vital signs, they're abnormal. They're going to be hypotensive and tachycardic. And that's how we know that we're actually kind of progressing from the beginning stages to something a little bit more serious. Again, cool, clammy skin with that kind of ashen pallor, right? They're cyanotic, the dry tongue and excessive thirst. They're going to have dizziness and weakness. They may have nausea or a headache from being hypotensive. and trying to vasoconstrict, and then their vital signs are normal to elevated. Heat stroke, the easiest way to think about this is altered mentation. When your patient becomes altered because of the heat, this is the most serious heat injury, and this occurs when the body is subjected to more heat than it can remove, and then the body's compensatory mechanisms are overwhelmed. The body temperature will rise to a level at which the tissue actually starts to destroy itself. Now, the people that are going to be the most likely to suffer this injury are going to be people that are performing vigorous physical activity in an extreme environment. There could be a sudden heat wave with people not being able to actually be prepared for this, and then children left in a locked car on a hot day, right? The temperature extremes inside of a car in a summer day are astronomical. I mean, somewhere in the neighborhood of anywhere from 140 to 180 degrees, and it doesn't take very long to overwhelm a child in that. The signs and symptoms are going to be hot, dry, flushed skin. They're going to have an elevated body temperature. Their LOC is going to be decreased to unconscious. They'll have massive changes in behavior because they're obtunded, and then they may go into seizures. Another telltale sign is that they lack any perspiration. The body is already overcompensated and they no longer can perspire to evaporate or radiate any heat off of themselves. So we're looking at the transport decision for primary injuries of heat, and this is if the patient has any signs of heat stroke, transport immediately. These patients are going to be a little bit fragile for you. They're going to have high temperature, red, dry skin, altered tachycardic, and they're going to be poorly perfused. These patients are already kind of in that decompensated shock. The altered mentation was the big tip for you. Again, the vital signs are going to have a falling blood pressure indicating that they're in decompensated shock. Their skin condition is going to help you distinguish between exhaustion and heat stroke. Do they feel like they've been perspiring, or are they dry? And then use your pulse oximetry to kind of help navigate what's going on with their particular perfusion status. Do they need oxygen or other things like that? Now, trying to cool these patients down is probably a good idea, and this would be just lightly misting them with some water and then kind of getting some airflow across them. We obviously want to have an air conditioner on in the back of the rig if we have that, and giving them fluids to rehydrate them is going to help tremendously. Now, in regards to a radiation exposure, this is exposure to non-ionized radiation. This can happen from cell phones, microwave ovens, and UV light from the sun. The long-term exposure from UV light is one of the main risk factors for skin cancer. In regards to treating a sunburn, this can absolutely fall into your first-degree burns, all the way up to a second-degree burn where we have some severe tissue damage. And remember that this is more about the overwhelming amount of sunburn than it is how bad the sunburn is. We can have somebody who only has first-degree burns, but they have them everywhere, and so every inch of their surface area of skin has enough damage that this is causing some significant problems for your patient. Now we're going to talk about water emergencies and drowning is death from suffocation due to the submersion in a liquid medium. So if we have a submersion event, this is a patient who will have lost consciousness while being submerged in that liquid, we'll say a pool, and they at least survive temporarily after the suffocation event has happened. Typically this was called a near drowning, but it's not really an official term anymore. It's either drowning or non-drowning, and again, that's based on whether or not that patient was at a point where they lost consciousness underneath the surface of water. There are several risk factors for people that experience a drowning incident, and this is alcohol consumption, a seizure disorder, geriatric patients with cardiovascular disease, and then unsupervised access to water. These are your small children that have accidental drownings in pools. The drowning is the last cycle of events caused by panic in water. Drowning in itself is considered the last cycle of events caused by panic in water, and this is patients who were unable to swim. They were unable to make their way to the surface to actually continue to breathe, and so they will go into those last throes or spasms before they lose consciousness. We want to make sure that we consider hypothermia in a drowning or a submersion event, because there are specific changes to what's actually happening in this particular case. Now, moving forward into some more of the water injuries, we're going to talk about diving, and these are serious water injuries, and this is with or without scuba gear. And the problems really kind of come from the increase in pressure as the diver or the person goes deeper in the water. The problems that result is the person who's performing the dive may panic, and they will cause themselves some kind of injury or actually exacerbate the problem and then create the situation in which they've drowned. Now, you can have descent injuries, and this is by somebody who's taking a rapid dive down through the deeper water, and pressure again compounds. For every 33 feet of water that a patient dives into, the atmosphere increases one single time. So at the surface level of the ocean, the atmospheric pressure is 14.7 pounds per square inch. And as that person dives down to, say, 33 feet, the experience is going to be 29.4 pounds per square inch of pressure, and this is a squeeze problem. The pain that's caused by this will force most divers to return to the surface, and this can be as simple as the atmospheric pressure trapped in the sinuses or inside the tympanic membrane, causing significant pain in the skull, which will make most people want to come back up to the surface of the water. Now, there are some rare emergencies where divers will actually continue down, and then they have some kind of issue with their diving gear. They may have the wrong concentration of gases based on what they were expecting to dive at, or they have some kind of regulator failure. This can cause drowning or create the patient making a rapid ascent, and rapid ascents come with their own set of problems that cause their own injuries. Now, the ascent injuries are usually the most serious of the injuries, and this is typically from air embolisms, and that's because the gases that are inside the bloodstream due to your ventilation on the scuba gear will actually kind of become bubbles inside the vasculature, which will cause that air embolism or gas embolism. This is normally caused by things like nitrogen and other mixes that are in the gas. An air embolism can occur in a dive as low as 6 feet, and then these can also, just depending on what the pressure is, if the regulator was to fail, the resultant influx of gas pressure can cause a pneumothorax or a pneumomediastinum, which is where we get air that is ruptured out of the lungs and has now created like a gas pocket around the heart underneath the sternum. So signs and symptoms of an air embolism are going to be blotching, froth at the nose and the mouth. This is kind of that frothy sputum. There's going to be severe pain in the muscles, joints, and the abdomen. And again, this is because all these gases are now kind of reforming and becoming bubbles throughout the body. And then they will feel dyspneic and then have difficulty with their vision. Some of these situations will be called decompression sickness, or as they're lovingly known as, the bends. And those are those bubbles of gas that are obstructing all of the blood vessels. And again, this is because as that person rises up from that pressure, it takes a little while to kind of offload the concentrations of gases back out into the surrounding atmosphere, which would be the water that they're surrounded by, and we're looking for that kind of equalization of pressure as they come up. And this is why most divers have to ascend in set levels. There's very specific numbers that they're going to use when they're coming back up to the surface, and they have several minutes that they have to spend at every level of pressure so that they can equalize out and not create these bends. Now, some of the bigger complications of the bends or the decompression sickness is if they get these gas bubbles, they can block complete blood vessels, and this could affect large portions of capillary beds, and then all of that tissue that's on the other side of this air bubble or gas bubble is now being starved of its normal blood supply, which means it can no longer get oxygen or nutrition, and it's going to go into anaerobic metabolism and then eventually cellular death if it's not rectified. One of the only ways to treat this, obviously without taking a patient back down to a set level at a dive, is to place the patient in a hyperbaric chamber, which is going to simulate the same thing, and then they're going to slowly bring the patient back to the current atmospheric pressure at whatever location this is. Now, being that we're mostly considering most diving to happen somewhere near sea level, and this could be any of the Great Lakes or in the oceans, most of these are going to bring it back up to 14.7. Now, our particular area is at 5,000 feet, and there are several places where divers will actually go, and this can create its own kind of emergency. But remember that everything is relative. So any kind of body of water that's at 5,000 feet is going to have significantly less pressure, much like the atmosphere at its surface level. Unfortunately, there's not a whole lot of treatment that we can do for these patients. It's BLS and a monitor, and then they need to go to a hyperbaric chamber. And in our local area, there are no hyperbaric chambers left. The last one was dismantled, I think, about a year or two ago. So any submersion incident can be complicated by some kind of C-spine injury, and quite often there can be submersion events or drownings that were caused by a spinal injury. This could be something as simple as a person kind of cliff diving in shallow water and they've created a spinal injury, and that ultimately causes this drowning. So make sure that when you're dealing with something in regards to a water rescue or like a submersion incident or drowning, that we understand what the mechanism was behind it. Were they just basically poor swimmers? Was there something else that contributed to this with alcohol, or was there some kind of physical trauma associated with it? I'm going to just kind of gloss over the recovery techniques. If you're a diver, then this is kind of something more your forte. But really, this is a specialized rescue. And unfortunately, if we have people who are kind of doing diving, this is more body recovery than it is actual patient recovery or rescue. Now, one of the small things that we want to touch on is that if you have a cold water drowning, you want to attempt full resuscitation measures on them, regardless of how long you think that they were under the water and have been drowned. There's a thing called the mammalian diving reflex, where cold water will cause the epiglottis to fold over and snap shut against the larynx, and then we have laryngospasm, which actually causes what we would call a dry drowning. This is where the patient has not inhaled a bunch of fluid, either being saline or seawater, like a salt water, or fresh water, which causes two different types of injuries in the lungs. But again, in this kind of dry drowning and the hypothermia, because the hypothermia slows metabolic function down, these patients are actually very likely to survive the event, especially if they're young. There have been documented cases where people have been resuscitated without deficits of greater than 60 minutes of being submerged in cold water, unconscious, without a pulse. Now, in regards to these kind of diving emergencies where we have somebody who's drowned, make sure you put the patient on their left side, try to let any kind of fluid drain out of their nasal and oropharynx, and then if we need to, we're going to use abdominal thrust or CPR to assist ventilations, and then administer oxygen and keep the patient warm. All right, now we're going to move into high altitude injuries, and there is just a couple of these, and we'll kind of briefly go over this. The first is the dysbarism injury, which is caused by differences in the surrounding atmospheric pressure and the total gas pressure of the body. And this would be perhaps somebody that's suddenly thrust into a low pressure area. Maybe they were in some kind of capsule, or we'll say maybe even a plane that had a pressure adjustment for the passenger compartment that is now suddenly depressurized, and the body has not had the chance to kind of equalize with that, and then we end up with the pressure differential between the atmospheric pressure and what's inside the body. Then we can talk about some altitude illness, which is caused by the diminished oxygen at high altitudes and what that does to the central nervous system and the pulmonary system. And let me be very clear, the concentration of oxygen is the same at sea level as it is at 20,000 feet. It's just the pressure, which then is going to give you the overall amount, right? So percentage-wise, it's going to stay the same, but because the pressure is different, we actually have an expansion of gas, which is going to give you less overall molecules per breath. And so this is what's causing that kind of hypoxia without actually understanding that it's hypoxia. So a couple of the different high altitude illnesses is the acute mountain sickness, which will either be high altitude pulmonary edema, which is HAPE, or high altitude cerebral edema, which is HACE. Now both of these are just purely the body kind of pushing interstitial fluid into either the pulmonary system, or we're going to increase the fluid that's around the cerebral spinal fluid or in the cerebral spinal fluid, and so the brain will take on some kind of swelling. The treatment of high altitude illness is obviously oxygen. Get them away from the height that they're at, which is the decreased pressure, and get them to the appropriate facility for treatment. Anytime we're out in the wilderness, we want to talk about lightning injuries, because unfortunately lightning is the third most common cause of death if you're in an isolated environment, and this is because we're typically out in a open area and we become the target of a lightning strike. The most common targets are boaters and swimmers and golfers, and again, this is an open area, and you now become the ground rod. And then anybody who's exposed to these areas, you want to be one of the lowest targets in a area that's out and open like this, right? And so when we're talking about that, like, one of the worst places to be is right next to a large tree. So if you find yourself in a position where you're trapped by a really nasty thunder and lightning storm, you want to make sure that you try to get down to a lower elevation. You want to stay away from anything that's going to attract lightning. More often than not, cardiovascular and nervous system injuries are observed when somebody is struck by lightning. The cardiac arrest is a common cause, and this is because we send such a surge of energy through the body. We actually kind of override and cause spasming in the electrical conduction pathways inside the heart, which will normally lead people into what we call ventricular fibrillation. And there can be significant burns that are usually superficial, but they can be full thickness depending on how much energy has been actually passed through the body. Okay, in regards to medical care on lightning injuries, if you are out in an open area and you have a storm that's impending and you feel tingling and the sensation of your hair standing up, this means that you've become electrically charged, and you are now more than likely going to become the object of excitement for a lightning strike. If you are responding to perhaps a lightning strike, we're going to do triage in reverse that we would normally do. We're looking for the patients who are in cardiac arrest or respiratory arrest. These are the patients who are extremely viable. The other patients are still all awake and alert, or they're just injured and they're breathing and they have their own cardiac function. We're looking for the people that we can convert back into a normal sinus rhythm or get their respiratory drive back online.